So, should I really use testosterone as a female? Is this even safe? If it's so safe and so good, then why won't the FDA approve it? Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine. Welcome back to Hump Day Hormones. This is season 2, episode 70.
Oh my gosh, we are old grandmas now.
We geriatric.
I love it.
I know.
I feel like people ask, like, how do y'all keep talking about stuff? Like, how have you already done this many episodes? We don't know, but there's no end in sight.
I know.
It's going to keep going and going and going.
I feel like my husband has equal questions. Like, how do you keep talking? How are you still having opinions?
Right. And you get us on these microphones and talk about anything hormones, and we're like, blah,
I know.
spill it,
I know. And I am kind of like, if anybody watched the George episode with my son, I am kind of like him. Like, something about this microphone makes me happy. So
yeah,
it's just fun. Okay, so today we're going to talk about the safety of testosterone, because I feel like the last episode we did, episode 69, was about what it's good for and what we know the proven benefits of testosterone is. And so that's great, but is it safe? Can we do that? And so this is where things get kind of nuanced. So we're going to talk about what the data shows. And I feel like the caveat here is that we're talking about using physiologic doses of testosterone. Mm-hmm. So if you are, not using physiologic doses, if you're getting overdosed with a pellet, if you are a trans individual and trying to transition to a man, I'm not talking about that. I'm talking about females staying in female physiologic range, just because that's our lane right now. Mm-hmm. Not that there's anything wrong with any of the other things, but just that's not our lane at this moment. So we're talking about when we're using female dosing. The truth is that we see no significant increased risk for cardiovascular disease or breast cancer. So the 2021 ISWISH, that's the International Study for Sexual Health in Women, that guideline in 2021 showed that randomized trials in postmenopausal women with hypoactive sexual desire disorder did not show signals for cardiovascular events or breast cancer, but the evidence base still has limits, especially for long-term outcomes, because the deal is that the studies that have looked at this usually were for like 24 months or less. And so we don't have some study of like a woman being on testosterone for 10 years. So I think, that's kind of our problem, is that we don't have long-term safety data. But what we do have is like testosterone data testosterone's been used in men for like since the 40s to 50s, 1940s, 1950s. And men, keep in mind, or like the trans population, they're using 10 times the amount of testosterone that we're using. And, we'll kind of get into that. But like if they're fine at 10 times the amount we need, then like, why wouldn't we be fine? And so I think there's a lot of like, you can really like split hairs about like, well, you don't have a 10-year study on females. Like, well, no, but I have, you know, studies going back to 1950 on males using 10 times the amount that we're using. So, yeah.
Well, and I think in the same breath, like we're, you know, extrapolating data from studies done on men and applying it straight to women, you know,
all the time.
Like all the studies that were done prior to 1990, whatever, before females could even be in studies, like all of those years and years and years, the studies that were done, we just said, okay, this info applies to women as well, but we didn't even study them. So it's like, okay, just,
I know,
you know, we're going to get fired up about this.
It's hard not
because
to.
it's hard not to.
It's hard not to because, like, not only because, like, I personally just feel like that there's such a double standard there, but also because, like, I'm the one sitting here looking at people's labs, hearing their symptoms, and knowing full well that they would benefit from testosterone and that if they were their husband, I could give it to them and their insurance would pay for it. But because they are the wife, and you know that their insurance is not going to cover it and it's not FDA approved, and I mean it's not terribly expensive, it's not, there are reasonable ways to get testosterone, but it's just infuriating that like that same person's male partner could probably get it covered by their insurance at 10 times the amount that we want to use as female.
It's also really hard whenever you've got a patient that you know, have prescribed it for, and then you follow back up with them in a few months, and in between time they've seen their primary care doctor or their, you know, another physician that takes care of them or their other gynecologist or whatever, and they have been like hounded about using testosterone because they saw testosterone on their med list. And they were like scared to even keep using it. And so there's just like all these roadblocks in the way. And, you know, I feel like just talking about it like we are, there's people like Kelly Casperson and stuff doing things at the federal level. But just getting it, just making people aware about those differences and everything, because not a single doctor would bat an eye about a guy being on testosterone.
No,
really.
They'd be like, good for you, man.
Yeah, high five,
homie. Okay, so what we do worry about, it's really like a dose dependent phenomenon with testosterone. So side effects are all going to be dose dependent, and there's a little bit dependent on like genetically, how does your 5-alpha reductase enzyme work? So I mean, that's really kind of up to Jesus how well that works, but like that takes you from testosterone, or like what we'd be giving you, bioidentical testosterone, to dihydrotestosterone. And so all of the side effects, really, the acne, the oily skin, the hair growth, the voice deepening, the clitoral enlargement, you know, all these side effects are with high doses of testosterone, or people who just have these like really, really overactive 5-alpha reductase enzymes. So some women are super sensitive to it, and they're probably the people who just have these enzymes that are like taking all their testosterone to dihydrotestosterone. You just don't know who those people are. And so you have to kind of go slow with your testosterone dosing, because you could give 2 women the exact same dose. One gets a bunch of acne, the other one's totally fine. So you have to kind of go slow with it. And it's not that tomorrow I got on testosterone and tomorrow I woke up with a mustache. That's not how that works. It's like you're gonna get really, really oily skin. I would say that'd probably be kind of the first thing you would notice, is like, my oil glands are, you know, working a little bit more. And then that's those oil glands clogging up pores with oil that then gives you the acne. So you're going to see oily skin, then you're going to see acne. Like if you're walking through the chain of events of things you would see. And it's like, think about the teenager acne. It's like on your back, on your jawline. It's like very like specific places for acne. And then like long term testosterone stimulation to hair follicles causes it to go from that like thin peach fuzzy vellus hair to like that coarse terminal hair. And so you could get some, hair changes and like chin hair. You could lose hair on your head, and then voice deepening, but that's usually with like really super physiologic dosing.
Yeah.
And then like clitoral enlargement. Like I will tell you, I have really never seen hair loss or clitoral enlargement or voice deepening.
Yeah.
Those are not things that people are walking in here like.
Yeah. And I think, knowing all of those potential side effects, I think that's where it is just important to have close follow-up, especially when you're starting testosterone or adjusting the dose or whatever. You got to follow these people's levels, and you got to follow up with them and talk to them and make sure that we're not running into any of these side effects.
Yeah. So, I just want to go through specifically like cardiovascular risk, because that is something that we get asked about a lot. And it's kind of a misnomer of testosterone. I feel like that people think, well, if I get on testosterone, I'm going to get really, really thick blood and I'm going to get a blood clot. And I think that really what they're probably thinking of is male dosing, which again is 10 times higher than our doses. Like you're trying to get male testosterone levels like 800 to 1,000 or even more sometimes. We're trying to get female testosterone like 75 to 150. So it's much, much lower. And so because we are using so much less testosterone, we don't see the same effects. And so the same things that men are counseled on is not the same like risk profile as women are going to have. So the 2019 Global Consensus Position Statement, which like, what does that even mean? I had to like, come on, like, what does that even mean? Global, I mean, it's like the whole world, right? So it's basically this international group that looked at evidence-based guidelines. So it's usually to help standardize practice, because we don't have, like when something has an FDA approval, it comes with a drug insert, right? It comes with like the package insert that tells you all the things. Well, when we don't have FDA approval, it's literally the Wild West of like, the FDA is not regulating this, like who is regulating this? And so this global consensus position statement tried to kind of standardize things based on evidence that we have. And it says that in studies using doses that are appropriate for normal premenopausal levels, testosterone is not associated with higher blood pressure, higher blood glucose, or higher A1C. There's no significant short-term adverse lipid effects, and that they did notice a non-significant trend, but a trend towards DVT, but it was not significant, and that data were insufficient for myocardial infarction or, heart attack and death. So, really, I mean, like, if you are going to your PCP and they're like, this is going to make your lipids worse, this is going to give you high blood pressure, it's like, on what basis are you saying that? Because
show me.
Yeah, we don't have that data to prove that. And in fact, we're using such low doses that we don't normally see that. So, we have the backup here saying that in all the trials they reviewed from across the world, they did not see those things. Now, granted, there is, in full disclosure here, the trials that they were looking at were usually for up to 24 months or maybe not even that long. So they're not super long-term data. But, we, again, don't have those studies until someone wants to fund them and do them, or until we just have enough women that have taken testosterone that we can retrospectively kind of look and say that. So
right.
That time will tell, I guess. And, we'll get that data as we move through the space or as more people do the studies. But
I think in the meantime, it's just we know as much as we know right now. We know safety. We're, knowing how well that it can work, that it's worth having a discussion about.
That's right. And then I feel like because hormones sort of by the FDA and by a lot of people, primary cares, pharmacists, whoever, hormones just get dumped into this bucket of like a hormone is a hormone is a hormone. And so testosterone is a hormone. And so hormones cause breast cancer. And so, this gets misconstrued that every single hormone affects the breast exactly the same. But that same 2019 global consensus statement says testosterone therapy does not increase mammogram breast density, and that short-term transdermal testosterone has not been shown to increase breast cancer risk. It also says that randomized trial data are insufficient to assess long-term breast cancer risk. So that's the thing is, these trials are short. They're 24 months or less. We don't have long-term data. And then there's this kind of extra caveat that women with hormone-sensitive breast cancer were generally excluded from those trials. So it's, we didn't study I had breast cancer and now I want to take testosterone population. So it is sort of, caution is advised in that group. And like we talked about last episode, estrogen comes from testosterone. And so if you had an estrogen receptor positive breast cancer, it is possible that testosterone, gets converted to estrogen and you therefore could stimulate an estrogen receptor. But I feel like that sets up this big breast paradox that we have in that testosterone really can have two different biological paths in breast tissue. And this is so interesting because there are spaces where they are studying testosterone and giving it to women with breast cancer and like metastatic breast cancer and getting good results out of that. But then in the same time, breast, like I just said, if they convert to estrogen, you could stimulate estrogen receptors, which wouldn't be a good idea in an estrogen receptor positive breast cancer. So pathway number one is like direct androgen receptor effects. So many breast cells and many breast cancers have androgen receptors. We don't talk about that. We talk about that your breast cancer is estrogen receptor positive or progesterone receptor positive, but is it testosterone receptor positive? We don't know that because we don't talk about that. But when testosterone binds the androgen receptor in some settings, it can slow cellular proliferation or counter the estrogen driving signaling or promote differentiation, inhibit tumor growth signals. So those would all be really good things. And like if we needed to target that, testosterone might be a good way to do that. And so research is currently actively studying androgen receptor biology in breast cancer. But like, it's not always bad. Like sometimes it's in fact good for the breast tissue. And so that is like, there's so much more to be determined in that space, but I think it's like so interesting. And then obviously pathway number two comes from the aromatization to estradiol and potentially stimulating those estrogen receptor in an estrogen receptor positive breast cancer. But, that the outcome really would depend. And so that's what nobody likes to hear is like,
right.
What people want to know is it always bad or is it always good? And I feel like the answer is it kind of depends on your tumor subtype, your androgen receptor expression, your estrogen receptor status, your aromatase activity in the tissue. So it may be that like we have a really interesting thing to offer, like the subset of women who are like triple negative breast cancers. So they, have estrogen receptor negative, progesterone receptor negative, and the androgen receptors may be actually a therapeutic target and in those women. And so that is really cool because that is the hardest. I don't treat breast cancer, but from what I understand, those breast cancers are traditionally the hardest to treat because there is nothing to latch onto. There is nothing to target. If you have an estrogen receptor positive breast cancer, that's easier to treat because we have estrogen receptor blockers. And so like tamoxifen and all that, those breast cancers we can easily target and easily treat. But these triple negative people, it's like, we need a target. We don't have a target. And so it may be that some of these androgen receptors could be that target. And I think that's so cool.
I think it is too.
Yeah. And I mean, in that way, I mean, what we don't want anybody to like go away from this hearing that like, oh, so I should take testosterone because it's gonna block my estrogen receptors and be good for me. I mean, no, absolutely not. Talk to your oncologist if you've been a breast cancer patient, and we would never give hormones to a breast cancer patient without complete agreement from their oncologist. But what I'm saying is this is a very active area of research, and the answer is not going to be in the end that it's bad, that testosterone is always bad and nobody ever with breast cancer can have it. Like, I don't think at the end of the day, when this all pans out, I think there's going to be a subset of people that can have it and a certain subset where it may actually be beneficial and we may actually be using it. So,
well, and kind of the same with estrogen is in any of these people, I think that there needs to be a conversation, it shouldn't be a hard no. There just needs to be a conversation, and you deserve that conversation if you're one of these people,
That's always where it gets like so nuanced, and you have to have somebody that's willing to sit down, hear your story, maybe even what we call the oncology. They probably know us by now. We call the oncology office a lot because I just want to run things by them. I want them to be on board. I don't want to be over here like the hormone cowboy over here just doing my own thing.
Right.
I want everybody to be in complete agreement. And I think now we have enough data to stand on that we can like do that in a very educated way. And I have never, ever met with any kind of like, ill will or hatred from those people. They're, I think they're
really
appreciative that we are, value their advice and that they want women to feel good too. They want to cure your cancer and you obviously to go on and live, happy life. But, not in their defense, they are not the treaters of the hormone problem. So, I mean, I think they're happy that somebody's doing it. So we've never really been met with any kind of pushback from any of that. But I mean, we've been told no sometimes, but we've never, not in a rude way.
Yeah, which is fine.
And sometimes I'm like, I feel like you're going to say no, but I just want to ask.
Yes. Yeah. And like that, worst case scenario, you're told no, like that's okay. I mean, they know more about your cancer and type and all of that kind of stuff than we do. So yeah, I mean, I'd much rather run it by them first.
That's right. And then just one more study, 2024. So this wasn't that long ago. It was in the Journal of Sexual Medicine, looked at women. It was like in this certain network, like an insurance database network from 2009 to 2022. And they showed that testosterone was shown to be safe. This was a 3-year observational trial, but they showed no increased risk for breast cancer or cardiovascular disease. In fact, the observed risk were lower in some groups. So, there's a slightly longer than 2-year trial. We're working on long term. We've gone from 2 to 3 years here, but that's an observational trial. What every gold standard medical trial wants is a randomized controlled trial. I don't know that we're going to get that.
Yeah. Yeah. And in our next episode, I mean, we're going to kind of go down the rabbit hole about like why there are those studies and trials, why testosterone is not FDA approved. So just so kind of like where we're coming from and where some of this like, probably frustration kind of comes from. But so yeah, I mean, we'll get into all of that. But yeah, I think it's super cool just to know like, even from these studies that, 2 and 3 years that not a significant breast cancer risk, not a significant cardiovascular risk.
Yeah.
I mean, that's definitely reassuring.
For sure. Yeah. And I think that, we've talked a lot on episode 69 and now 70 about really good things about testosterone. And then I feel like we sit here and we talk to women about your testosterone's kind of low. Your total testosterone is 15 and your free testosterone is 0.4. And I think you would really benefit from some testosterone. And here, I think it will be great for your mood and your energy. I know it will increase your libido. Women report all these great things from it. It will likely even help your muscle mass a little bit. You may have improved workout recovery. You may even improve a little bit of your insulin resistance. And it's so good for your bones. And they're like, hell yeah, I want some. And I'm like, okay, well, here's the problem. It's not approved by the FDA and it's not covered by your insurance. And immediately you see people's balloon like deflate a little bit. Kind of like, well, what? If all this stuff you just told me about it is true, like, what do you mean? It's not why not? If it's so great and it's so safe, then why the heck has the FDA not approved it? And I feel like that is an excellent question and one we're going to address on episode 71. So,
yay. Love it.
So yeah, our little disclaimer, just remember that this is for educational and supportive purposes only. Your body is unique. Always talk to your personal healthcare provider, whether that be your oncologist, your hormone provider, whoever, before you make any changes to your healthcare routine. And y'all have a great hump day.